I would like to welcome Dr. Motov. So, how are you from the other side of the world? And I would like to welcome whoever joined us just recently to join our second journal club with Dr. Motov. So please join me to welcome Dr. Sergey Motov, and he's an emergency medicine physician and the research director at Maimonides Medical Center in Brooklyn and NY, and a professor at SUNY Downstate. He specialized in safe, patient-specific AD pain management, focusing in non-opioid and opioid-sparing strategies. He has published over 70 peer-reviewed articles and has lectured globally in pain management in the ED. So please welcome me to welcome Dr. Sergey Motov, and the floor is yours.
Thank you so much, Dr. Algorani, for such a wonderful introduction. Greetings, everyone. Greetings from New York City. I am truly excited and honored to be here with you today. And before I start, I just want to take this opportunity again to thank Dr. Algorani for giving me this amazing opportunity to meet you all virtually and share some of the experiences and talk about very topic that I'm very passionate about. But more importantly, I just want to take this opportunity to thank each and every one of you, whether or not you are pediatric emergency medicine trained emergency department clinicians, whether or not you're adult emergency medicine physician, pediatrician, or any clinician who's attending this particular webinar. I just want to thank you for what you do, for making difference in people's life, in children's life, and every day. We're going to talk about pediatric pain management, and I really wanted to thank Dr. Algarani for putting this beautiful title together: Smarter, Safer, and Kinder. And we're going to focus as a more of ED approach or ED update to it. Before I start, I have one disclosure. I am a co-founder and chief executive officer for a company called S&T Info Corporation that offers educational, public speaking engagement, and educational and consulting services in acute pain space. Without further ado, let's take a look at our objectives for today. We start with discussing current state of pediatric pain management globally, and then we're going to go into this unique set of opportunities that we can do to make pediatric pain more safer, more effective when it comes to its management. And I'm going to follow Dr. Algarani's lead when it comes to safer, smarter, and kinder way of doing so. Let's start with a general spiel. Pediatric patients. We all know how challenging at times, or pretty much all the time, is to manage pediatric pain, starting from the moment they enter our emergency departments to try to assess their pain, to treat their pain. And it's a double hit because in addition to manage pediatric patients with their pain and anxiety and unhappiness and anger, we have to manage their parents as well with pain, anxiety, and anger. So it's sort of a double hit. And when it comes to pediatric pain management, I just want to emphasize that over the past 15 years, I believe pediatric emergency medicine clinicians and ED clinicians across the globe made a huge advancement in improving pediatric pain management. We've increased, or sort of gotten better with respect to our understanding of neurobiological aspect of pediatric pain or pain in general. And we're using this CERTA concept by utilizing non-pharmacologic and pharmacologic treatment modalities at much greater extent. We've mastered skills of ultrasound-guided nerve block, and slowly but surely this particular skill is really entering world of pediatric emergency department as well when it comes to pain management. So we did make a progress, and I'm very, very happy about this. However, despite the progress, pediatric pain on a global scheme of things still remains underappreciated, underassessed, and frequently undertreated. So let's look at each of them. And the underappreciation of pediatric pain is a very multifactorial component. It has clinical component to it. It has a cultural component to it, even societal and then family component. But three things I want to emphasize is start with the clinician. The first is that there is still, unfortunately, misconceptions and there are still misbeliefs with respect to pediatric pain sensitivity and pain perception in children. It's still there. It's outdated. It really breaks my heart to admit this, but some people, some clinicians still believe that children may not perceive pain at the extent that adults do, which, as we know, it's not true. Second component when it comes to underappreciation of pediatric pain is the fact that clinicians too often tend to underappreciate the pain because in a group of preverbal and at times developmentally challenged or delayed children, their ability to provide verbal cues non-existent, and clinicians not understood to pick up on nonverbal cues. And lastly, there's a component or tendency to misattribute distress, particularly related to crying or agitation, to behavioral problem rather than a pain. When it comes to underassessment of pain, it's a global phenomenon, and there is a numerous supporting evidence clearly stating that issue with the timely assessment of pediatric pain, it's paramount, and it's not only in the United States, it's probably globally. And several reasons comes to this as follows. All too often, clinicians use validated pain scales, which are age and development appropriate, in inconsistent basis, not using them consistently, or using them inappropriately for not appropriate age or developmentally developed group of children. Second of all, which is particularly in the United States, there's a great deal of racial disparities based on race and ethnicity of children. For instance, Black, Hispanic, American Indians, and Alaska Natives all too frequently have a delay in their assessment of pain and have adequate assessment of pain in comparison to their white counterparts. Another issue when it comes to underassessment of pediatric pain lies with the fact that EDs are fast-paced, multitask environment, and at times clinicians just don't have enough time to sit down and get full history and properly assess pediatric patients' pain. Time of essence. At times, because of the very hectic environment, there's a frequent delays when it comes to getting to the pediatric patients and assess their pain. And then there's a family component, which can be two sorts. On one end, clinicians at times not engage in family frequently enough to be their advocates when it comes to assessing pain in their children. Or family comes in with the preconceived biases, fears, or there's a cultural phenomenon tend to force the families to underreport the pain in their children, or fear of the fact that their children may get an opioid. So this cumulatively leads to underassessment of pediatric pain. And the last thing I want to mention is undertreatment of pain, which is, again, not as perfect as I want it to be. Factors related to undertreatment of pain as such. Well, there are gaps in knowledge. Knowledge when it comes to pain physiology in pediatric patients, pharmacologic knowledge when it comes to currently available analgesics, and more importantly, there are gaps in pharmacologic validity when it comes to utilizing a proper medication with a proper dose and proper route. There is a fear related to opioids utilization in pediatric patients, known as opiophobia, and there's an outdated fear of masking diagnosis, particularly abdominal pain, which has been debunked so many times in pediatric patients, thus leading to undertreatment of pain. Similarly, particularly in the United States, as I mentioned earlier, when it comes to underassessment, racial disparities when it comes to timely, adequate, and effective treatment modalities are prevalent. Thus, Black children, again, Hispanic, American Indian, and Alaska Natives are frequently having their pain not properly treated, not adequately treated in the ED and at discharge. Another thing that I want to bring up why pain is undertreated is over-reliance on misconstructed, and at times I say word detached from reality, a guidelines recommended, for instance, by WHO, aka pediatric analgesic ladder, which I believe is misconceptualizing the way we need to manage pain in pediatric patients. Time is of essence. The frequently delayed in provision of adequate analgesia is an issue. And the last thing is, at times, pediatric patients at discharge leave emergency department in moderate to severe pain, despite the fact their pain was treated in the emergency department. Now, if I want to focus a few more things, particularly in the United States, in addition to everything we've talked about this, such as underappreciation, under advance that clinician made in the United States when it comes to management of pediatric pain, their issue lies in timeliness. Timeliness when it comes to assessment, and timeliness when it comes to provision of effective analgesia. For instance, a study by Valani, the reference is on the bottom of the slide, in 2023. It was a large multi-center retrospective study, included 5 community emergency department in the country that specifically look at children presenting to their respective department with variety of acute painful conditions. And the study showed the following: 25% of children did not have formal pain assessment. Less than 1 in 5 children received analgesia during their stay in the emergency department. Median time to analgesia delivery was 90 minutes. 90 minutes. The oral route was the most commonly employed route in 67% of patients who did receive analgesia. Paracetamol and ibuprofen were two most commonly used analgesics. Another study by Club in 2020 looked at children under age of 18 presenting to the emergency department with severe limb trauma, demonstrated that 54% of pediatric patients left emergency department with moderate to severe pain, with median pain score 4 out of 10 on numeric pain rating scale. These are very concerning numbers. Very concerning numbers. In addition to underassessment and timeliness and racial disparities, a list goes on and on and on and on. So the question is, what do we do? Well, thanks to Dr. Al Garaini for coming up with this beautiful, catchy title, we can make a difference. We're already making a difference, but we can make a bigger difference by adhering to the smarter, safer, and kinder approach to pain management. Before we dive into details, I just want to reemphasize and remind you the few basic principles when it comes to pediatric pain management in the emergency department. I do sincerely, profusely apologize.
So
So
that
before we've had temporary interruptions. I am so embarrassed, but please forgive me. So before I go into the smarter, safer, and kinder way of managing pediatric pain, I just want to re-emphasize and remind you the general principles when it comes to successful and effective pain management in pediatric emergency department. And there's a four simple components. Seem simple, but we just need to remember them. You've got to know the child. You've got to know the family. You've got to know their physiology. And of course, you need to know the therapeutics you're using. And when it comes to actual pain management, remember the three things: treat pain early, treat pain aggressively, and reassess frequently. And now, without more ado, smarter, safer, and kinder. And what I decided to do, I decided to extrapolate on each of the words. And if any of you like mnemonics, hopefully you enjoy it, because what you're going to see is going to be entertaining. So let's start with the first component. How do we manage pediatric pain in a smarter way? And it has to be, in my opinion, evidence-driven, has to be timely, and it has to be thoughtful. And here's how we're going to be doing this. So this is SMARTER. S stands for systematic assessment. M for multimodal analgesia. A for awareness. R for the reassessment. T, triage-initiated treatment. E, empowerment of patient, parent, or caregiver. And R, resource utilization. Let's dissect and let's look at each of them separately. First, S letter in SMARTER S. Start with the systemic assessment. And the main principle when it comes to systemic assessment are as follows. You've got to assess pain proactively. You've got to assess pain consistently. And more importantly, you have to use age and development appropriate ways of assessing pediatric patients' pain. That's very, very important. How do we do this? Well, remember, the assessment of pediatric pain has to be tailored. It has to be based on stage-specific development, which offers unique framework into pain and symptoms and signs of pain in respective age group. Similarly, selection of assessment tools, which we're not going to talk about right now, all the skills, you guys know this better than I do, should be tailored to pediatric development stages and their level of communication or ability to communicate. In preverbal children, use your observational skills in addition to patient or caregiver report. In verbal children, in young children, you can use pictorials, and in adult, older or adolescent children, you can use obviously adult scales. But more importantly, that trumps everything else. When you do talk to children, if they can verbalize their complaints, use open-ended question, and please let the child speak for themselves. Of course, engage parent or caregiver in their care, but remember, report from the caregiver and verbal children should not be superseding the report the child can give it to you. Get to the comfortable level with child. Use the language they understand, but try to have them speak the way they see, the way they feel, and how exactly they experience pain. Over the past 2 years, one of the biggest passion of mine was to explore the role of biopsychosocial profile in pain assessment and management across all spectrum of the department, including adults and pediatrics. And several studies I can come up with, they're actually coming from the surgical world. They're looking at the biopsychosocial profile or pain assessment in pediatric patients. Why is it important? Because we all know that pain is subjective, an inherently subjective experience that is affected or influenced by biological, social, psychological, and emotional component. So in addition to pain severity, precipitating alleviating factors, scales, intensity, therapeutics, we should probably look at more holistic approach when it comes to pediatric pain management and look at from the biopsychosocial perspectives. And these are the examples. In addition to purely descriptive way how pain, look into child's thoughts and feelings. Assess influence of the family and parent and factor cultural and societal components when you assess pediatric pain. Moving along, next letter in smarter, M. Let's talk about multimodal analgesia. And there's several concepts that I want to bring up to your attention. When it comes to pediatric pain management from respect of therapeutics, pain should be individualized, should be equitable, and should be pain syndrome specific. And that component should be braced and should be founded on the fact that non-pharmacologic and pharmacologic treatment modalities should be utilized. It has to be patient-specific and pain syndrome targeted, again, by utilizing non-pharmacologic and pharmacologic treatment modalities. This is just a refresher for you guys. You know this probably more than I do, but the simple things, we're going to start from least invasive to sort of more invasive. Remember, cryotherapy, aka ice pack, thermotherapy, aka heat pack, immobilization, splinting, sling, casting, all works. And then we go into distraction techniques, right? We're using passive way of distracting, whether or not there's a TVs, iPads, there's a passive virtual reality, or there's an active virtual reality, such as full immersive one, 3D full immersive one. And we can use cognitive behavioral components in DD, such as gaming, guided imagery, music. Even go to the basic stuff. We even have all the technological advances, such as coloring books and playing and doing puzzles. And of course, I had to put here, there is no apparent life without Buzzy at present. So Buzzy for the win. Advancing, moving from non-pharmacologic treatment modalities to pharmacologic treatment modalities. And we can start with a topical analgesia, which, as we all know, has been very effective and at times alleviating great deal of pain and suffering, angst among patients and their parents. We're talking about LAT in the United States, right? Eutectic mixture of local anesthetics, amyl cream. We're talking about vapor coolants, and we're talking about pressurized lidocaine preparations such as J-tip or lidocaine powders. All effective, all been proven to be very beneficial in managing pediatric pain. Moving from topical to orals, we have a variety of analgesics available to us. Oral paracetamol, oral non-steroidal anti-inflammatory drugs, right? At times, oral steroids will help. No oral route, or there's a contraindication, we can go to intranasal route. We can use opioids, we can use ketamine, we can use dexmedetomidine. And in the United States, it's expensive, but if cost is not prohibitive, even intranasal ketorolac has been found to be effective in management of pediatric pain. Similarly, inhalation or inhaled route is very important. Nitrous oxide, methoxyflurane, or we can use nebulizers to use opioids, to use ketamine, and even dexmedetomidine. We can use ultrasound guided nerve block from simple blocks such as digital block, dental block. We can use field block. And recently, I'm going to talk about it later on about the role of fascial plane block in pediatric pain management. And of course, last resort at times, so maybe first resort, it's intravenous route. Intravenous paracetamol, non-steroidal anti-inflammatory medications, opioids, ketamine, antiemetic, steroids, and list goes on and on and on. Now, this getting a little more interesting because last part of the title of the presentation is an update. And I just want to touch base on the current state of affairs when it comes to efficacy of this multitude of analgesics in pediatric emergency department. And I'm going to give you some of the most current data that I could come up with as far as update goes. So first systematic review meta-analysis, 8 clinical trials, 1,600 pediatric patients presenting to a variety of emergency department with a variety of acute painful condition, I believe mostly musculoskeletal, found that ibuprofen was the most effective analgesic, which possessed least amount of adverse effect. Better than paracetamol in combination with NSAIDs or opioids, and better than opioids. Another study by Al Sabri in 2025, 24 clinical trials, demonstrated that ketorolac, given parenterally, was found to be safe and effective in managing variety of acute painful condition in pediatric patient in their emergency department. And pool analysis out of 4 trials demonstrated relatively low risk of gastrointestinal adverse effect, about 1.5%, which is a really, really good number. If I want to capitalize on ketorolac, There was a randomized clinical trial conducted in the United States that demonstrated non-inferiority of intranasal ketorolac given at 1 mg per kilogram in comparison to intravenous ketorolac given at 0.5 milligram per kilogram in pediatric patients presenting to the emergency department with migraine headache. And of course, to top it off the ketorolac drug, several randomized clinical trials specifically looked at analgesic efficacy and safety of sublingual ketorolac given pediatric patients presenting with fractures or dislocations or severe abdominal pain. And what those two randomized clinical trials demonstrated that there were no difference with respect to analgesic efficacy and frankly better safety of sublingual ketorolac in comparison to sublingual tramadol. Original or initial dosing was 0.5 milligram per kilogram of sublingual ketorolac with a maximum dose of 20 milligram. Moving along, ketamine. One of the largest systematic review to date by Dr. Alan Eyes and colleagues that look at 4 randomized clinical trials, 2,500 pediatric patients. One trial looks specifically on intravenous route of ketamine at dose 0.2 milligram per kilogram. Another trial look at 0.2 milligram per kilogram of ketamine given intramuscularly. And 2 remaining trials look at intranasal ketamine at 1 and 1.5 mg per kilo. All 4 trials, 2,500 patients, clearly demonstrated non-inferiority of ketamine given intravenously, intramuscular, or intranasally in comparison to opioids, morphine, or fentanyl. However, administration of ketamine by each of those routes led to transient, short-lived, and self-limited increase in adverse effect, particularly nausea, dizziness, and psychoperceptual adverse effect known as feeling of unreality. Dr. Singh in 2025 did another trial meta-analysis and systematic reviews of 7 clinical trials, close to 489 patients, comparing intranasal ketamine to active comparator, mostly opioids. And what Dr. Singh and colleagues found that intranasal ketamine provided similar analgesia to opioids, had a similar rates or occurrences of needing for rescue analgesia. However, significantly higher, near about a factor of 2.5, number of patients in ketamine group experienced adverse effects such as excessive sedation, dizziness, unpleasant taste in the mouth, and nausea and vomiting. Moving along from ketamine, and the last trial I want to bring to your attention is the systematic review meta-analysis by Dr. Oleginik, published in JAMA Pediatrics in 2025, looking at pharmacological pain management of pediatric patients. 43 clinical trials, close to 5,000 pediatric patients. All studies looked at 4 main components: pain severity, need for rescue, symptom relief, and adverse event. And here's how they played out. So there were moderate to high quality evidence demonstrating the fact that non-steroidal anti-inflammatory drug had the analgesic advantage and superiority over placebo with respect to pain relief, followed by ketamine and followed by opioids. There were low or very low quality evidence stating that paracetamol alone in combination with NSAIDs or opioids and NSAIDs, as well as tramadol and codeine, had any analgesic efficacy in comparison to placebo. When it comes to rescue analgesia, NSAIDs as a group, in particular ibuprofen, with a high quality evidence demonstrated superiority over placebo and any other classes of the drugs. When it comes to symptom reliefs, which was defined as a complete resolution of pain or minimal pain, there were moderate to high quality evidence demonstrating lack of analgesic superiority of NSAIDs, opioids, even paracetamol in comparison to placebo. And lastly, when it comes to when it comes to adverse effect, both paracetamol and ibuprofen seem to have similar incidence of gastrointestinal adverse effect to placebo, particularly nausea, vomiting, diarrhea, and constipation. So these are the updates on efficacy when it comes to pediatric pain management. Moving along to smarter, now with A, awareness. And there's a few things I want to bring to your attention. There is a huge need for you to be aware of need for equitable, individualized, and pain-specific or patient-specific pain syndrome-targeted approach to pain management in the pediatric emergency department. There's a huge need or awareness. Be aware of the need for age and developmentally tailored pain approach. There is a need to assess family dynamic and inquire about the prior pain experiences. And lastly, there's a huge need to avoid assumption based on a age of the patient and their presentation. Just what I'm trying to say is there's a need to use evidence, use your smartness, use your approaches that you use on a daily basis, and tackle patient as such. R stands for reassessment. Well, issue with reassessment is that if assessment is slightly under, well, not under, frequently under-assessed, pain under-assessed, reassessment probably going to be following the same pattern. A few things to remember here. Reassessment of pediatric pain needs to be done with respect to the same scales that were initially employed prior to initiating pediatric therapy. In adolescent or teenagers, older children, it is my firm believer that pain reassessment and need for analgesia should be based on improvement in functional status of a patient. So function rather than absolute pain reduction should be the main driving force in older children because they can verbalize whether or not they have so much pain. Getting them to back to daily activity of daily living is the very important component. They may tolerate pain, but they will not tolerate the fact that they cannot ambulate, they cannot walk, they cannot move their arms and legs. So this is very, very important. And the last thing that frequently is omitted is the fact that pediatric pain needs to be assessed in the proper set intervals based on the medication that you're using. If it's a titratable medication, use it in the proper interval. If it's non-titratable, still approach the patient. Make sure you have a set timing that you're going to be approaching patients. And when you do, document pain intensity as well as the response to pain. This is important. T, triage-initiated, frequently used words, nurse-initiated pain treatment of pediatric patients. Numerous studies clearly demonstrated that nurse-initiated or triage-initiated approach to pediatric patient reduces time to analgesia in the ED, increases percentage or proportion of pediatric patients who receive timely and frankly at times adequate analgesia from the get-go. And of course, very important component is that nurse-initiated or triage-initiated treatment leads to improved parental satisfaction. What can be done? Again, departmental specific, hospital specific, but in my humble opinion, I believe it's within the purview with the proper training and proper protocols. The triage initiated treatment should evolve around topical analgesia, oral analgesia, even intranasal, inhaled, or combination of both. Just see, I'm not specifically focused on intravenous because that's a little tricky, but this topical, oral, and intranasal can properly be employed with a proper setting, proper education, fairly straightforward and easily. And remember, pain gets better, patients feel better, and parents feel tremendously better. E, empowerment of patient, which is very, very important, parent, equally important, and caregiver as equally important. And here's what I want to say. If you want to remember one word, it's listen. Listen to parents, listen to caregivers, listen again, and then listen some more. Listen, listen, listen. Engaging or empowering patients, of course, and parents and caregivers as an advocate and as a partners in entire treatment processes from pain assessment to pain treatment to disposition are the keys or is the key to successful, effective, and family-centered approach to pediatric pain management. This is very, very important. In addition to, when it comes to empowerment of patient and parent, always engage patient if they understand what you're saying, but always parents in shared decision-making when it comes to goals and objectives and expectations when it comes to pediatric pain management. Engage them in conversation or share decision making about natural trajectory of painful condition. At times, we're all aiming for the pain-free, but if you have a broken bone, you may not be able to achieve pain-free status. Set clear expectation. Explain what's going to happen. What's the natural trajectory of the pain to get better? How long will it take? Explain to them what analgesic you're going to be used. Be as granular as you can. Provide the name of the medication, route, and dose. Importantly, tell them what alternatives exist. And of course, don't forget about disclosing short and long-term benefits of the medication, as well as adverse effects and risks of giving and taking these medications. Always communicate treatment plan to parents and provide a preview what to expect. And lastly, always provide detailed treatment plan at discharge with clear directions, clear instructions, and most importantly, return precautions. We get into the last letter in smarter, R, resource utilization. It's no brainer right now. We're all using electronic medical records. And the point I'm trying to bring here with this particular slide is to make sure whatever the order set you use or EMR is comprehensive. It's not only focusing on pharmaceutical and therapeutics. Make sure you have a checkboxes or whatever you created, and it has all tools that will help you to assess pediatric patients' pain, which are age and development appropriate in a comprehensive fashion, and make sure you have a checkbox that utilizes non-pharmacological treatment modalities as well. Make it very, very comprehensive. To the right, I'm going to put this here, and this is what I'm having conundrum. As you may see, my tendency, I try, and a person don't like standardized protocol. Why? Because I mentioned to you earlier, pain is subjective, inherently complex, and individual component. Rather than standardize everyone to one particular protocol, let's say abdominal pain, but all abdominal pains are different. Two patients with appendicitis may not manifest the same. What I'm proposing rather, create an order set that is created by all you in within your individual department. Use evidential support to put together a list of analgesics, non-analgesics, and other treatment modalities that you believe are effective, has a good evidential support, and you as a group, as a faculty, as a colleagues, all comfortable using them. And then you get to choose, and then you get to individualize your approach to pediatric patients. And again, it brings us to the earlier slides I mentioned to you earlier, not blindfoldedly follow the, let's say, WHO pediatric letter analgesia, which is really, really outdated and needs to have some retweaking. And the last thing I want to bring it up, technology is advancing. Consider utilizing AI. AI can help with the pain assessment. AI can help to be part of the clinical algorithms within your EMR, specifically identifying patients at risk for adverse effect or bad drug-drug interactions, which I'm going to talk about in a little later. And lastly, make sure if you like enough and if you can have a capacity, have a clinical pharmacist in the emergency department, have a child life specialist in your department, and have a consultants available. It may not be applicable to all of you, but something to consider. These are the group of people, our allied healthcare providers, who are indispensable in ensuring that pediatric pain gets safer and better managed. And here we go, my dear colleagues. This is our first component of safe and effective and very efficient pain management in pediatric patients, which is SMARTER. Once again, systematic assessment, multimodal analgesia, awareness, reassessment, triage-initiated treatment, empowerment of patients and their parents, and resource utilization. Moving along, and we go into SAFER, which underlying concept or overarching goal is to minimize the risks and provide maximum protection. How are we going to do this? By using SAFER approach. S stands for safety, safe dosing and safe routes of administration. A, avoidance of dangerous drug-drug combinations. F, fail-safe processes. E, integration to the electronic medical record or EHRs. And R, risk mitigation education. Let's start with the one important one, which is safety of dosing and choice of route and drugs. And here I was going to summarize what needs to be remembered. You've got to know the drug, you've got to know the dose, and you've got to know the route. If you don't, go back to it. It maybe sounds a little harsh, but I'm under sort of a spell of this, and that's been one of my biggest pet peeves is that if you do not know the drug, you cannot use it. If you do not know the dose, you should not be using it, let alone if you don't know the route. This is going to be detrimental to your successful pain management. Make sure, I'm not asking you to memorize every single medication, but the one you're comfortable with, got to know them, got to know them, and got to know them. Here's a few updates when it comes to safe dosing and choice of route and drugs. I know that intravenous paracetamol is one of the most common analgesic used globally when it comes to pain management. I'm not talking about the fever right now. But one thing to remember when it comes to intravenous paracetamol, there is a potential for iatrogenic overdosing by the virtue of the fact that physicians too often prescribe or always prescribe the dosing in milligrams, but the medication gets delivered or administered in milliliters, which leads to nearly tenfold increase in potential for overdose. So milligrams to milligrams, milliliters to milliliters, double check what the order is written for and how it gets administered. Non-steroidal anti-inflammatory drugs, we've talked about at length. We all know, and the overarching goal when it comes to safety dosing of pediatric pain medication, weight-based dosing. No exceptions, right? We're talking about under 50 kilos, it should be weight-based dosing and based on age and everything else. Elderly, on adult, adolescent children, we can use different approaches to it, but weight-based dosing is the paramount key to success. Now, when it comes to non-steroidals, we know 10 milligram per kilogram, right, at times 5 if it's less than 30 to 40 kgs. In paracetamol, it's 15 milligram per kilogram, know the maximum doses as well. But if I'm focusing on adolescent children and teenagers, 15, 16, 17, they're in the realm of adult dosing. Here's a few components I want to bring to your attention. There's a concept of analgesic ceiling when it comes to NSAIDs as a class of analgesic, which implies it's a pharmacological phenomenon that says after reaching certain dosing threshold, any future increase in dosing will not result in additive or additional analgesia, aka meaning there's a cap beyond which NSAIDs stop working as analgesic, they continue working as anti-inflammatory drugs, which leads to significantly higher occurrences of adverse effect. Here's an example. Analgesic ceiling dose for ibuprofen is 400 milligram. For naproxen, it's 220. For ketorolac, is 10. And for diclofenac, it's 50. I can go in ketoprofen, it's 25. And dexketoprofen, it's 12.5 to 25 per dose. Again, this we're talking about older children and adolescents and teenagers. But for the younger children, weight-based dosing. Similarly, avoid intramuscular injection for NSAIDs when you're dealing with grown-up children, adolescent teenagers, because intramuscular injection causes pain and injection, unpredictable absorption. In about 25% of cases, patients do not get appropriate relief. Lastly, I want to bring up the concept of NSAIDs rotation. As we all know, all NSAIDs inhibit non-competitively COX-1, COX-2 enzymes, which interferes with prostaglandin synthesis, reduces inflammation and pain. However, within the NSAIDs as a class, there are 6 subgroups. Each subgroup has intermediates that do not depend on arachidonic acid metabolism. And those differences in those intermediates serve as a physiologic basis of improvement in pain by switching NSAIDs between different classes. Example, you have a patient who's been receiving ibuprofen for 3 days for musculoskeletal injury and don't seem to be having any improvement. Before you jump to opioids or something else, you can simply switch them to diclofenac or ketorolac orally for 2-3 days because you're rotating them between the classes. And at times you'll be surprised how much of analgesic efficacy you can achieve by simply switching analgesic subclasses within the NSAIDs group. Opioids. Despite the opiophobia and everything else, they are still very effective part of analgesic armamentarium when it comes to pediatric pain management, specifically in the setting of acute pain. Key to successful opioid therapy is titration. Titrate, 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 irrespective of your initial dosing regimen, whether or not you use a weight-based, which I'm strongly encouraging, or fixed dosing. Reassess patient appropriately and titrate. Remember, pure mu receptor agonists lack analgesic ceiling, which means the dosages can be titrated until 2 things happen. Pain gets better or side effects becomes intolerable. Technically, third, when patient tells you, please stop, I don't want it anymore. Please, 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 in adolescent and old children, avoid intramuscular injection of opioids. It leads to excruciating pain, unpredictable absorption, and a whole host of additional complaints related to septic aseptic necrosis and myofibrosis. I know it's not as maybe as prominent in your region, but in the United States, there's a opioid crisis has been a very big deal. And in adult and pediatrics, of course, and for that very reason, I usually try to bring up the component honoring euphorogenic potential of opioids, try to avoid highly euphorogenic opioids. For that very reason, I believe that morphine provides better analgesia and least potential for euphoria in comparison to its other semi-synthetic and synthetic counterparts. Lastly, if we focusing purely on safety and efficacy, nalbuphine appears to be equal or even superior when it comes to pain relief in pediatric patients with acute pain given intravenously in comparison to morphine or fentanyl, but has significantly better side effect profiles. It causes less respiratory depression, less nausea and vomiting, and less pruritus. Dosing 0.05 to 0.1 mg per kilo given intravenously or 0.1 mg per kilo given intranasally. So if you do have ability to use nalbuphine and you believe that patient in front of you will rather benefit from nalbuphine rather than morphine or fentanyl, go ahead and do it. Lastly, again, it might not be as applicable to you, but I strongly recommend to prescribe intranasal naloxone, mostly to adolescent and old teenagers when they leave emergency department with prescription for opioids, because you never know what's going to happen. Potential for misusing, potential for taking more than prescribed is real, and naloxone is a life-saving medication for this type of patients. Ketamine. As I mentioned earlier, that big systematic review clearly demonstrated the utility with respect to pain relief of ketamine in pediatric patients. Remember, weight-based dosing is 0.1 to 0.3 mg per kilo given intravenously. Avoid IM route. There's no data and it's very painful. Rather use intranasal route or inhaled route. And please remember, rather than giving ketamine as an intravenous push dose, try to use short infusion over 15, 20, even 30 minutes. Why? Because the incidence of psychoperceptual adverse effects, such as feeling of unreality, which are usually fairly bothersome and unpleasant to a patient, are directly related to a dose and speed of injection of ketamine. That's why IVP, intravenous push dose, is out. Consider short infusion. In addition, to reduce this unpleasant psychoperceptual bothersomeness, such as feeling of unreality, use pre-ketamine administration coaching with parents and older children, providing clear instructions on what to expect when utilizing ketamine for pain control will greatly alleviate anxiety of patients and their parents, set expectation differently, but more importantly, will sort of prime the patient to potential mind-altering experiences that they can have by virtue of receiving ketamine. Consider slow infusion over 15 to 30 minutes, and at times you can start with a lower end of a dosing regimen, such as 0.1 mg per kilo. Remember, you can always titrate. Local anesthetic here is very straightforward. We do using them, and rightly so. Know the maximum dose with epinephrine or without, with adrenaline or without, and get in the habit to double check the dosing. Variety of preparations. If you do use lidocaine, remember, make sure it has to be warm temperature. Make sure you buffer with bicarbonate to reduce acidity. All the things has been proven to reduce the pain upon injection. And always on the back of your mind, especially if you're embarking on a path of regional blocks, always think about local anesthetic systemic toxicity and have your intralipids nearby. Few words I've alluded earlier in my talk that we've made a great deal of advances when it comes to interventional pain management techniques, specifically focusing on ultrasound guided regional blocks, right? We're very comfortable with simple blocks. I'd say digital block for, let's do, finger or toes, painful conditions. Field blocks, comfortable as well. Isolated ulnar or radial blocks, we're very comfortable. Science advanced to the fact that femoral nerve block, even brachial plexus block, can be effective for managing a variety of musculoskeletal trauma pediatric patients. But with the fact that our knowledge got a little better, we expanded our horizon. There is a push for fascial plane blocks, specifically in the thoracoabdominal region for patients presenting to the emergency department with a variety of painful condition. One thing I want you to remember, facial plane blocks, as of right now, they don't really provide analgesic superiority based on the currently available data in pediatric literature, but there's a great deal of anatomical variation with age, and smaller the child, greater potential for complications. For instance, transversus abdominis plane block, traditionally used for painful complaint related to abdominal wall hematoma, abscesses, and even studies show the pain of visceral origin, hernias, plain hernias, incarcerate hernias, or even appendicitis. But it's a large volume block. So if kid gets too much of a local anesthetic, there's a potential for local anesthetic systemic toxicity. Similarly, serratus anterior plane block, which is primarily resolved for traumatic thoracic injuries, rib fracture, sternal fracture, or acute cutaneous pathology, at times, again, require a large amount of local anesthetics and can lead to local anesthetic systemic toxicity. Based on a narrative review of UCAL from 2025, the study authors clearly put together that erector spinal plane block that used for thoracoabdominal pathology in pediatric patients seems to provide better balance with respect to analgesic efficacy and safety. Few more words, nitrous oxide, very effective, ultra short, quick on and off. But remember, adverse effect are nausea, dizziness, excessive sedation, and especially when you combine nitrous oxide with fentanyl, excessive sedation becomes a problem. So be very big concern, and at least be aware of the fact that sedation can become over excessive. And lastly, when it comes to methoxyflurane or inhaled Pentrax, inhaled methoxyflurane, always be careful when you choose the eligible patient. Patient with a familial history of malignant hyperthermia, underlying expected or established hepatic or renal insufficiencies should not be the candidates for this particular medication. Safer. Going to A, avoidance of dangerous analgesics and their combinations. This is what is going to get a little tricky and a little tasty because I did do my research and I believe that tramadol and codeine are relatively frequently utilized in the Middle East, in your region, and probably globally across the globe. So here's where I'm coming from, and I'm going to just say it out there. If you can, don't use these medications. Why? Well, here are the reasons. Tramadol, despite its misbranding as very effective opioid, it's not effective. It pales in comparison to actual effective opioids. It does not provide similar analgesic efficacy to morphine, hydromorphine, oxycodone, fentanyl, or hydrocodone. Furthermore, data from adult world, which was extrapolated to pediatric world, clearly demonstrated that NSAIDs alone in combination with paracetamol provide better analgesic efficacy than tramadol in pediatric patients with acute musculoskeletal pain. By virtue of the fact that tramadol is a dual analgesics. It's mu-opioid agonist and it's inhibitor of norepinephrine and serotonin reuptake. Side effect profile, it's really horrific. Look at this. It causes respiratory depression and overdose, seizures and repeated doses, serotonin syndrome, drug interactions, really bad one, especially with monoamine oxidase inhibitors. It causes hyperglycemia, hyponatremia, which clinically can be very detrimental, and its use associated with increased mortality, let alone there's a genetic variation how we metabolize tramadol. Codeine, similarly, it's one of the weakest opioids on the market, does not match analgesic efficacy of commonly used strong opioids. There's a great variation of genetic polymorphism. We all know this. P450, CYP2D6, right? All population can be divided based on the way we metabolize codeine, and based on our single nucleotide polymorphism, we can be poor metabolizer, intermediate, rapid metabolizer, or ultra rapid metabolizer. An issue becomes when a patient himself, or if it's an infant or newborn and the parent mama is ultra rapid metabolizer, large quantity of codeine will be metabolized to morphine, which leads to significant potential for respiratory depression and respiratory arrest. Interestingly, globally, 28% of ultra-rapid metabolizers, when it comes to metabolism of codeine and tramadol, resides in North Africa, East Africa, and Middle East. And just so happen that number or percentage of patients who are ultra-rapid metabolizer with respect to CYP2D6 in Saudi Arabia is 10.5%. In United Arab Emirates, 11.8%. Europe, close to 3 to 5, and the United States between 0 to 5%. So just again, be cognizant of the fact how dangerous this medication can be. And just to sum this up, the American Academy of Pediatrics put a set of guidelines in 2023, revised in 2024. Simple thing, do not give tramadol or codeine to children less than 12 years of age, period. Do not give codeine to children between ages of 12 or 18 who are suffering from obesity, sleep apnea, or do have severe lung diseases. And do not administer or prescribe codeine and tramadol to pediatric patients for relief of postoperative pain, those patients who are undergoing adenectomy or tonsillectomy. So this is it. I just put it out there. Again, it might be regional variability, it might be cultural thinking practices, but my only suggestion would be if you can try to avoid using tramadol and codeine in pediatric patients. Another thing is try to avoid in older children and adolescents. Try to avoid combination of opioids with benzodiazepines, gabapentinoids, and muscle relaxants because their combination lead to excessively high rate of respiratory depression and death by the factor of 3 to 10 in comparison to opioids alone. And lastly, in the United States, it's very prominent to combine opioids with paracetamol. So if you do this, always be cognizant and warn the patient and their family of potential of paracetamol overdose in case if patient decides to take more than prescribed medication that contain both opioids and paracetamol. F, fail-safe pain management processes. Key principles here. If you have it, fantastic. If you don't, we should create processes that detect, prevent, and respond to pain treatment-related complications in children. And here's how it works. We need to first, very simple thing, reassess patient regularly. In addition to pain, get in the habit to reassess their level of consciousness and level of respiration if you're giving them opioids and sedative hypnotics. Make sure your electronic health record within the order sets you embedded a guide rails or safety dosing alarm which will ring, bell, or pop up from the screen should there be potential for overdose risks. Similarly, it is important to standardize analgesic formularies and concentration. Why? It reduces variation and variabilities in dosing and formulations. Mistakes are prevented, overdose is avoided. Get in the habit to use two providers check for all high alert analgesics such as opioids and sedative hypnotics. Try, I know it's easy to say than done, distraction-free zone in the emergency department, but maybe there is a satellite pharmacy in your department. That's the place. The nurse needs to prep all the analgesic for pediatric patients according to weight-based dosing without being distracted. And if you can, if technology allows, use barcode verification on the bedside. Make sure it's a right patient and it's a right dose. And of course, don't forget the cardinal 5 rules of safe medication administration. Right patient, right drug, right dose, right route of administration, and the right time. EHR integration. We've covered pretty much most of it already, just to reiterate. Make sure you do have a built-in calculators for proper dosing based on the weight, and there are proper alerts, alarms, bells that will alert you should there be potential for overdose. Make sure there is a similarly guardrails preventing you from prescribing or administering drugs that have potential drug-drug interactions. Make sure the EHR has embedded pain scales, which are age and development appropriate. And just to pushing forward to it, in line what I just mentioned to you with respect to genotypic variation on codeine and tramadol metabolism, maybe not right now, as the technology advances, we can consider utilize personalized pharmacogenomic-based CYP2D6, P450 testing in the emergency department that will help us to figure out which patient, based on their metabolism, will have analgesic efficacy from codeine and tramadol, or which patient would actually have detrimental effect by virtue of them being ultra-rapid metabolizers. Last is risk mitigation. Fairly straightforward. Make sure we need to educate the staff about potential drug overdose, symptoms, red flags, and drug-drug interactions. And here comes the most important part, parental counseling. You've got to talk to parents about analgesic using alternative, adverse effect, short and long term, how to store the medication if they go home with it, and how to dispose of analgesic if they're not using them all. Make sure that parents understand they need to strictly adhere to your prescribing information. There's no variation to it. That's why you need to be specific providing timing and providing dosing. Not as needed. Be very, very specific when you prescribe your prescription. And encourage family and parents to follow your directions. Make sure you provide clear return precautions, is focusing specifically on potential recognition of symptoms related to drug overdose. And it may not be applicable to you, but in the United States, it's a common practice to provide opioid take-home safety sheet with information on how to recognize opioid toxidrome, potential for opioid overdose, and how to dispose unused opioids. And here we go, my dear colleagues. Our safer approach, safe dosing and route, avoidance of dangerous combinations, fail-safe processes, EHR integration, risk mitigation education. And the last thing is, which probably should be in the first one, kinder way to approach the pediatric pain management. Make sure we practice compassionate, developmentally sensitive, and family-centered approach. Everybody wins if you do this, but in a simple way, in a simple words, if you want to remember it. Be nice, be courteous, and be respectful to your patients and their parents. And here how it goes. K stands for kid-centered comfort and communication. I, integrated non-pharmacologic support. N for nurturing environment. D for dignity preservation. E for engagement with families. R, reduction of procedural distress. And I'm going to go over it. This sums up safer and smarter way of approaching to pediatric patients. And we all know this. It's just a good refreshment course. We're going to do rapid fire style. Kid-centered communication. The paramount here is you've got to descend yourself at the level of the kid based on their age, based on their development, and based on their communication ability. Tailor your approach. Use the plain words. Avoid hurtful phrases. No shot, no hurt. We're here to help. It's going to make your tummy feel better. It's going to make your head feel better. Always encourage comfort over restraint. Let child sit on mom's and pop's lap. Maintain upright position. Do not try to separate them without much of a need to it. And always leverage, if you can, help of child life specialists when it comes to preparation, coping, and specific, and especially during the painful procedures. Integrated non-pharmacological support, we've covered this at length. Positioning, behavioral method, distraction techniques. Always encourage family and children to have the items they're very comfortable with, blankets, toys, during painful intervention. Let them cling to them. It makes them very, very happy. And of course, utilize non-nutritive sucking, facilitated tucking, swaddling, and for certain painful procedures, utilize oral sucrose as well. Nurture environment. This is big. Important component here is you've got to validate the child's and family fears. I know you're afraid. We're here to help. We try to make you stay here as sort of fearless as possible. Avoid unnecessary separation. I already touched base on it. Make sure, in addition to physical pain, you get to know the child, as I said in earlier. So treat their emotional pain as well. Try to get to the bottom of it, what bothers them. At times, emotional component, but not they're too depressed, anxious, or stressed out, can aggravate painful condition. And focus on embracing this child-parent-physician partnership, aka triangle. Child on the top, physician and family. D, dignity. This is my favorite and probably one of the most important thing. The way I see it, no matter how old the kid is, they're a human being. Respect the human being. Focus on it. By respecting the human being, you will honor their age and their stage of development. And once again, you will adjust your communication and tailor accordingly. Listen attentively, participate actively in their care, not just only from the moment to say hi, assess their pain, and walk away. Guide them through it. Be their captain through entire stay in the emergency department. I cannot emphasize how important it is and how much of a difference you're going to make. And once again, provide emotional support. E, engagement with families. We've covered this at length just to reemphasize how important it is. Listen, listen again, and listen some more when it comes to parents. Engage them as active participants and allies when it comes to comforting their child, when it comes to explaining the procedure, explaining the medication, and advocating on children's behalf. Engage parents and caregivers in shared decision making. We've covered this already. Make sure you do talk again explicitly about therapies, risks, and benefits. And try to find time. I know how busy we all are. Try to find time to answer to their questions. Nothing works better than words that you provide, the comfort and confidence you instill in the parents when they're about to leave your emergency department. And the last thing is just to focus on sort of peri-procedural distress. Gentle a child or handle child gently. Make sure preparation comes as a paramount of importance before you embark on any painful procedure. And make sure you stay there throughout the process of recovery. Comfort hold, storytelling, countdowns, breathing, make them welcome, make them less fearful of the upcoming procedure. And lastly, try to minimize procedural trauma by, again, use topical anesthetics, distraction techniques, get live child specialist. And one of the important things is here, try to bundle care to reduce repeated distress, right? If you're about to place an IV, make sure you draw the blood at the same time or vice versa. So you don't have to torture, especially you don't have to repeat invasive procedure. Just try to bundle them based on expectations. What are you planning on doing? And here we are with a kinder, kid-centered comfort, integrated, non-pharmacologic support, nurturing environment, dignity preservation, engagement with families, and reduction of procedural distress. We're getting to the end, my dear friends. And the way I'm going to summarize this, as I mentioned earlier, managing pediatric pain is not an easy task. It's probably one of the hardest that comes to emergency medicine, but it's doable. You're all brilliant. You're all amazing. You've been doing this all your life. You've been all your years. And for those in training, you're going to be doing this. You're doing it currently. You're going to be doing this moving forward to it. So get comfortable. Understand this is what you're going to be doing for the rest of your life. And remember, four main components that started in the beginning. You've got to know the child in front of you. You've got to know the family. You've got to know the physiology. And for sure, you've got to know the therapeutics that you're using. And combining this with this beautiful, beautiful approach by using safer, smarter, and kinder way of tackling all together, what you're going to do is you are going to be able to help your patients, to help their families, to leave emergency department with much better state of mind and with definitely much better state of their pain than they were before. Because at the end of every shift, or let me rephrase this, at the end of every encounter, when it comes to pediatric patients in pain, the ultimate goal is to see the happy face, such like this. On this note, I want to thank you for rewarding me with the gift of your time. Thank you so much.
Thank you so much, Dr. Motov, for the great actually presentation and talk. You have utilized the mnemonics very nicely, which is surprisingly that you have utilized the smarter, kinder, and safer, which is really helpful to be utilized in our EDs as well. As well as you have shared a really great expertise, really summarized some of amazing articles that we have needed in our pediatric emergencies that would tackle the pain-free EDs. It's really truly inspiring, to be honest. It's a really amazing presentation, which makes my jaw dropped in the beginning and at the end, the way you closed it. So now we're receiving a couple of questions from the audience. So Dr. Abdullah is asking, first question regarding the neonate. Any preference for type of the pain treatment and painful procedure, such reducing hernias? This is the first question. The second question, with intubation, do you recommend pain meds like fentanyl, like the adult, or something else?
So, very good question. Thank you. Before I go into the question, I just wanted to thank you for such a kind words, such a kind remarks about my presentation, and I'm really elated. I'm thrilled to see that you've enjoyed my talk and you felt like the information provided was very, very useful. So, thank you for this, and thank you personally for creating this beautiful title for the presentation that allowed me to come up with this mnemonic. So, thank you, Dr. Algarani. Um, Neonatal pain management tricky, very, very tricky. And we can go from escalation to non-escalation. We talk about non-nutritive cycling and sucrose. We can use topical a lot. When it comes to hernias, ideally, I'd probably would consider utilizing opioid. This is the only medication right now we all know, right? When it comes to NSAIDs, depending on the part of the world where you are. UK allows NSAIDs to be used under 1 month of age, 1 month and older. Rest of the world, 3 months. In the United States, 6 months. So we can probably do paracetamol. It may not work. Some people even believe the paracetamol should be given very carefully to neonates, although it's probably given. If I am at the precipice to use analgesia for reduction for any neonates, I would use weight-based dose of opioids.
Okay.
As far as intubation goes, I'm sorry, the second question was intubation.
Yeah.
Look, it's almost, to me, the way I usually say it, it's inhumane to use a, let's say, paralytic agent without sedative. So you need to intubate with whatever the drugs you're using, and subsequently, once they're intubated, you need to provide the sedation. But not it's a fentanyl, but not it's a propofol. And I personally do not recommend use ketamine anyone who's 3 months of age or younger. But after that, you probably can use this. But sedation and analgesia or analgesia is the must. So yeah, if you need to choose an opioid, it would be fentanyl, and if you need to use a nice sedative, it's going to be propofol.
Amazing. There's a question, another question from the audience, Dr. F. I bet it's Dr. Faisal. He's asking, is it better to do the cannulation in the presence of parents as way to comfort the child, or not, because it might increase the anxiety of the nurse to cannulate him?
I am big advocate of getting parents in a room and pretty much follow any type of procedure, probably even including intubation if time persists to it, only because with the proper preparation, with the proper utilization of topical analgesics, right? Most importantly, you honor the time and you use AMLA, will give enough time to pass it. Not 20 minutes, not 30 minutes, give maybe 40, 50 minutes, plus distraction, plus child life specialist. There shouldn't be an issue then. And once you prep the parent what to expect, it'll be very comfortable for the patient and the parent to have their presence in the room while nurse or physician place an IV. Yeah, I'm a big proponent to it.
Okay, so you highly recommend and suggest that
I
to
would
keep it
highly recommend it. Yes.
while cannulating the patient. Great. There is another question by Dr. Hidayah. She's asking, would you recommend any opioids meds for patients with inflammatory bowel disease and severe pain? And if so, what is better and safer?
Once again, I would. I am a big proponent of safe and judicious and effective opioid therapies. You can start with a non-opioid therapy for patients with IBS. NSAIDs may or may not help. Some believe NSAIDs may aggravate the condition. Ketamine probably would be very useful for this type of presentations. But if you choose an opioid, morphine is the opioid of choice. But I've alluded to the fact that the younger patients, maybe nalbuphine, which we don't use in my shop, but nalbuphine might be even safer. Similar analgesic efficacy, but significantly less nausea, vomiting, pruritus, and respiratory depression. So between morphine and nalbuphine, I would use these two. If this two fails, fentanyl to the rescue.
Yeah, okay, amazing. So there's no contraindications to have used opioids as morphine in IBD patients.
No.
Came across contraindications to be used morphine in such cases.
Well, again, you use properly crafted, tailored, weight-based, titratable way of giving opioids. You can do
Uh,
small increments, you can start slow and go low, or you can start a little more aggressive. But at present, unless there's a pure mechanical obstruction somewhere in a spat of intestines that technically will preclude giving opioids, although I don't even, no, scratch that. No, you can use opioids.
No, okay, great. There's another question by Dixon Robert. He's thanking you about the amazing talk. Plus, he's asking regarding severe pain management of vaso-occlusive crisis for patients with sickle cell disease. We're utilizing morphine currently as a first line. So, is there any other recommendations other than opioids to be utilized in vaso-occlusive crisis?
Yes. Uh, Thank you so much for kind remarks and thank you for this question. Opioids, NSAIDs may not be, and ketamine. If I had to choose two classes of drugs, opioids and ketamine. And traditionally, well, I don't know how it's in a region, vast majority of vascular patients in the United States, they're sickle cell patients, I'm sorry, they're a vasculopath. It's very challenging to establish intravenous accesses in those patients. So at least from the get-go, you can utilize intranasal route for opioids, nebulized route for opioids. Once IV is established, morphine plus ketamine, morphine alone, ketamine alone as a short or continuous infusion, or combination of both.
Amazing. There's a couple of questions from my side. My first question, what are your go-to non-opioid strategies for acute pain in children in ED? The second question, can you share any challenges or lessons learned from implementing safe analgesia protocols in pediatric emergencies, especially if there is any protocol has been initiated from your side in NY hospitals? Because we don't have any protocols per se or standardization in our region. If you can share any.
So the go one and go two for me when it comes to pediatric pain management is NSAIDs. If there's no contraindication, and again, we're under in the age which you're allowed to give NSAIDs to a pediatric patient, that would be my go one drug. And then opioids, and then ketamine. Or we can do NSAIDs, ketamine, and opioids. As you probably got the drift, current state of evidential support is really, really stating that in a setting of moderate to severe pain, paracetamol may not be as effective as we as we thought. Am I against it? Not entirely. You might combine two, but just want to have an expectation you may not be achieving a pain relief that you're accustomed to see. For that very reason, non-steroidals, ibuprofen, opioids, and ketamine. These would be three class of analgesics that I would strongly recommend to use for pediatric for moderate to severe, severe to intolerable pain in the ED. Now, when it comes to protocols, I'm going to just share my experience, what we did in our department. As mentioned earlier, I do not believe that standardization of pediatric pain management across the region will increase visibility of pain. But if we focus on a patient-centered outcome, standardization of the protocols will not do this. Why? Because standardization removes the very individuality. Again, pain is individual subjective experience. What we did in our shop, we've created an order list or order set that we collectively as a department, you put all your attendings and fellows and residents together if you want to, and you all going through the list and you decide this is a good medication, this is a good dose, good route, good evidential support, we like it, we've used it, it's safe, we're going to be using this. Create the menu or the list of the analgesics, non-analgesics, and other modalities that you believe will greatly benefit your patient, and then build this into your EMR and then use it as you see it fit by use one, two, three, four different modalities out of this list, customizing to individual patient. This what we've done in my shop, and it's been very well received. We even created this sort of analgesic superset or analgesic set. It's not standardized protocol. It does not differentiate headache, abdominal pain, back pain. It's a order, it's a list of commonly used analgesics, and we use them according to each particular presentation.
Yeah. Understood. There's another question from the audience as well. Dr. Rawan, she's asking, thank you for the amazing talk again. And do you observe in high input ED flow that using the approach of pain-free AD painless is interfering with your patient flow and turnaround time?
Great questions. At times, yes, and at times, no. And I just want to be very transparent. My ultimate goal and overarching goal all here is to focus on the pain-free. I just want to make sure that all understand the limitation of this particular approach. If we're all going to advertise our department that we provide pain-free, and we will make sure you're free from pain, it may not have a right connotations. In certain situations, you succeed. Let's say you have a nurse med elbow. Yes, they come in pain, they'll live without pain, they'll be loving you for the rest of your life. But if you do have a broken leg or broken arm, you're not going to be pain-free. So I just want to be very careful how we use words when it comes to pain-free. Pursuit of pain-free should not be the goal. Optimization of pain, relieving pain to the level that patient is willing to accept, and primarily focusing on improving and restoring their function. That should be the goal. And once again, in a busy days, yes, the pursuit of this pain-free sometimes may jeopardize the flow, but for the most part, it doesn't. If we follow smarter, safer, and kinder approach to pain by using everything I mentioned in my talk, I think we will greatly succeed in it.
Amazing. Thank you so much. Is there any questions from the audience? Last question we can accept before ending our talk.
And Dr. Algarani, if I may, after this talk, I'm going to email you a handout. I prepared a special handout for all of you. So if you'd be so kind to receive it and can distribute among the attendees, I'll be very, very happy. And while I will not be able to share the slide, I'm going to create a PDF document with all the slides in it. And I'm going to share with you as well, because I want you guys to have it. And if you find it useful, if you can use those mnemonics and apply it to your daily activity, I'll be forever grateful.
Thank you so much. It is really amazing. And thank you for your help and even your talk. I think we don't have any questions in our chat, even in our group. So I would love really to conclude here. Thank you so much, Dr. Motov, for your really amazing and inspiring talk, as well as for your help and answering for that benefit questions. And I'm sure the audience, they get highly benefit from your amazing talk. And I hope you and your family will get a chance to visit us in Saudi anytime sooner. And really, any last talk you would like to tell us before we end our Zoom?
I cannot thank you for your graciousness, for your incredibly warm welcome, and for such an inspiring introduction and ending. In my turn, it's been a delight to meet you. It's been a delight to meet your colleagues. It's been a delight to have this opportunity to talk about a topic that I'm very passionate about. And again, I want to thank you personally, Dr. Algarani, and everybody on this call for rewarding me with the gift of your time. I appreciate it. It's been a pleasure. Thank you so much.
Nice to see you. See you soon. Thank
See you
you.
soon. Bye bye.
Bye. Bye.